all everybody here in, let's see, today, Savannah, Albany, and Athens. Coming to you live from Augusta today. I know you'll let me know if you can't hear me, so I'll get started. Anyway, a couple of things. Of course, we had an exam last hour and felt real good about the outcome. Hopefully you did. Our average was right around 90, which is what I shoot for on that. Still going through some of your comments. I will, in the next class or two, pull up the ones that most of you seem to have either problems with or questions about, and we'll go over those, but always glad to answer your questions on that. Overall, feel real good about it. We're going to be moving on into more daily applicable things, I would say, in pharmacy practice as we go, but we don't want to forget, the background and the laws and the basis for what we're doing. We'll still kind of loop back around to those, and of course, remember that the final exam is comprehensive, just like life and the NPJE. So you will see some of that material again. So don't purge your memory, okay, on that. A couple of things. Let's see. I think I had some things pulled up here. GPHA has posted another update for legislative updates. Still nothing real active going on, but they have a picture of the hard copy of the bill. Don't have the text of the bill, but you can see all these signatures on there. These are co-sponsors, so they feel really good about this. This is the bill they've been talking about, which has been referred to as the anti-steering bill, to try to make it harder or prevent PBMs from steering their PBM patients directly to their own pharmacies and not allowing the local pharmacies to have a chance at them. Still interested to see how the wording is going to be on that. Hopefully that's going to drop, as they say. We'll actually have a number for that next week, and that will probably be the bill that we try to kind of follow and see the whole long, tedious process it goes through. We'll see how far it gets this year. Remember, this year is the first of a 2-year cycle, so they actually have 2 years to get things passed if they introduce it this year, whereas the second year of a 2-year cycle, if it doesn't cross over by 3/4 of the way through the legislature, it can't go anywhere. So they really, this is a year to get things going that might take a little while to convince people to vote for. Looks like they got a lot of support for sure, but let me tell you, the PBMs are going to bring in all their high-paid lobbyists. We do a lot of dinners. We're going to have a lot of jets flying into Charlie Brown Airport trying to lobby against this. So they're really trying to get as many people on board with this as possible to begin with to kind of help assure that goes through. The other thing they mentioned here is the bill we've talked about since pretty much the first week is the dextromethorphan restriction. I don't really see that that's got a lot of traction. It's definitely not being pushed by pharmacy interests as far as requiring a valid ID of someone 18 or older in order to purchase a dextromethorphan product. Realize this affects more than just pharmacies. It's sold in all kinds of places. And again, not real sure how that's going to work out. But we'll see. Other things, let's see, that's something I'm going to talk about in class today when we get to it. I keep hearing a lot of questions and discussion out there about CBD, CBD oil, CBD additives to drinks and coffee and meals and stuff. It's everywhere. We're not going to spend a whole lot of time on it. I would love to do just a whole separate section, but we've got some many other laws. We will talk about it a little bit as we talk about the marijuana regulations, medical marijuana in Georgia. But a couple things have been happening near us. One thing down in Florida, law enforcement there has started enforcing in certain counties the fact that their definition of the law, under their definition of the law, CBD is a cannabidiol and is as illegal as marijuana. So they're telling people, particularly these head shops, convenience stores, and at least in McIntosh County, one vape store sells CBD oil. We don't know what the source is. We don't know what the purity of them is. And in Florida, at least, many law enforcement agencies are going in and telling people, giving them letters saying it's illegal for you to sell this. So we'll kind of see how that goes. Not real close, but something that I feel like some of you might see or hear about. In New York, they're shutting down the ability for restaurants and particularly coffee shops and tea shops from adding CBD as a food additive. This goes back all the way back to that boring Food, Drug, and Cosmetic Act. as a supplement, dietary supplement, it's less regulated than if it's a food additive, believe it or not. And they're saying it has never been proven safe. It is not acceptable to put CBD in any form into food or drinks. I don't see a whole lot of Starbucks cups here. There's one back there, but I know in Athens we've got Trader Joe's. I'm real interested in y'all in Athens doing some research for me or letting me know if you've seen it. I would expect a place like Athens and the coffee shops and things like that possibly to offer that as an add-on. But let me know if you see that. Again, it's not considered illegal in Georgia, but it better not have above that minimal level of THC in it, or of course it is illegal. Let's see. Okay, well let's get back to the notes. We're going to pick up where we left off. I was going over and over and over about what is a legal signature, talk about the electronic signatures, fax versus electronic. Definitely the physically applied signature stamp is not acceptable. Showed you the actual reference in the Georgia law to that. Used to see this on a more regular basis. Really, I think it's been replaced a lot by electronic prescribing. But used to have a lot of practitioners' offices that would use stamped prescriptions. With the problem with the stamp is you don't know when or who applied it. We're going to talk today a little bit about agents of the prescriber who might prepare a prescription for a signature. If you already have something with a signature on there, which is illegal to have a pre-signed prescription, it really, again, takes that control out of the prescriber's hand if they've already signed those blanks, so it is illegal to have those. We talk about exceptions to requirements of the signature, basically drugs that are available on standing orders in Georgia, naloxone more recently, and definitely one you hear about in the news quite a bit, but also the auto-injectable epinephrine. If it's available, it is good. It is possible for them to get that on a standing order basis. I'm sorry, not a standing order, but on an order that is not patient-specific. A prescriber still has to write it, but they can say this is for the Little League chapter in the city or for the school system or somebody like that to have that on hand for training people to use it in case of emergency. Okay, the next thing up, and I believe this is where we stopped before, had to do with physicians, assistants, and nurse practitioners. That's something we have talked about before, and anytime we do loop back around and talk about some of these things 2 or 3 times, sometimes during law class, think of that as underlining or making it all big, bold blue. That means that's an important topic. There are the bays, Dr. and Mrs. May coming in. So that's an important topic that you really need to have in mind. It's a distinction. Georgia is very unique as far as how we regulate mid-level practitioners. So here goes again. The prescription may be signed by the physician's assistant if they have authority to prescribe. Again, remember we talked about a few weeks ago that they must have, in addition to their license, they must have that job description for a PA that includes the ability to prescribe, and it should be restrictive to the types of things they can prescribe for. Okay? The second one is a little harder to understand, and I've actually taken that slide out of your notes, but I'm going to show it to you, and it's actually in your notes if you want to refer back to it. It's just hidden. I haven't totally erased it yet. But up until just a few years ago, there was actually a requirement on a PA prescription. Let's go ahead and flip to that. And I light blued this out. Basically, it should be struck through. This is no longer in the law. But believe it or not, and as cool a monitor as this is, it doesn't allow me to write on it like in Savannah. I'm going to try to highlight what I'm talking about right here. This was a statement that had to be on the prescription that was signed by a PA. Had to be printed on there. This prescription is authorized through Dr. XYZ MD by physician's assistant and the physician assistant's name. Now, I never saw this actually done, even though this was on the books for many, many years. A few people say they did have, PAs that had prescription blanks that already had that printed on it, things like that. But it was never done. It was in the law. It was always a point of contention between the pharmacy board, particularly GENA, and the medical board. So the best way to resolve that is just change the law, or in this case it was a rule in medical regs, and they took that part out. So that extra statement is no longer required if you're, and I know a lot of you end up talking about law topics with your practitioners or preceptors, people you work with out in the real world, and if they talk about that, tell them they can rest assured that's now been taken out of there. The prescription, however, must contain the delegating physician's name, address, and phone number on that prescription. So most of the time that's going to be pre-printed, but it needs to have that information on there. So should you need to contact the supervising prescriber, you would have that information actually on every single prescription. And that's legalese term, that third point, any prescription drug order form containing less is not legal and should not be offered or accepted by any pharmacist. Okay? But the key thing is they took this part out, which makes it, thank goodness, match the nurse practitioner's requirements. In Georgia, they can only write for C3, 4s, and 5s if it's in dangerous drugs. We'll talk about dangerous drugs because that came up on the exam. They can only write for that if it's included in the job description. So they're not licensed to prescribe. They're licensed to be a PA. But they have to also have that job description in their protocol with that supervising prescriber's signature on it that says what class of drugs they can prescribe and if they're allowed to prescribe controlled substances. In addition, for controlled substance, they have to have a DEA registration, Drug Enforcement Administration registration, in order to be able to prescribe controlled substances. So all these things have to be there in order for their prescription to be legal. Now I can hear in your mind, you're saying, gosh, how do I know that on all these people? Am I going to have to start calling all these people? No, don't go there. We're going to show you how the board has relieved us of that responsibility. We have to be prudent and think about it, and if we suspect that someone is prescribing off their job description, we have to follow up with it. But the board does put the responsibility on the supervising physician and the nurse practitioner, or in the case of the APRN or PA. They do not need a co-signature if these things are present. Okay? The co-signature really has no legal status. If it's signed by another prescriber, it becomes that prescriber's prescription. It's not the PA's prescription co-signed by their supervisor. It is the supervising prescriber's prescription. This is important in things like C2s. Okay? A PA or nurse practitioner, as an agent of a prescriber, might prepare that prescription for their signature, but they give it to the prescriber who's authorized to prescribe C2s. They sign it, it becomes that person's prescription, not the PA, nurse practitioner, nurse, nursing assistant, receptionist, patient, whoever prepared it for the physician's signature. Shouldn't be the patient. The delegating physician is responsible. Pharmacists do not have responsible verification, but you should be careful and wary of that. Now, some of you may work at a place where if you get PA prescriptions for certain drugs, you have to call and verify. Anybody under a situation, you see a few people nodding their heads. And that's fine. You can always do more. But as we'll see here, the Board of Pharmacy actually says as long as it appears reasonable in your interpretation, you don't have to do that. Okay, APRNs, again, that's Georgia legalese for nurse practitioners. And I'll use both, kind of use them interchangeably, but when you see APRN, that stands for Advanced Practice Registered Nurse. That is a PA in Georgia. They can write for 3, 4s, and 5s. Excuse me. And dangerous drugs. Let's talk about dangerous drugs. And here I didn't make dangerous drugs capital, and I do try to do that. I did do it here. This came up on the exam. A couple people wrote some comments and said, not really positive about that yet. Dangerous drugs are non-controlled substances that require prescription. Okay. So the way the regs are written, they start out talking, the feds start out talking about C2s, and they talk about 3s, 4s, 5s, 5s that require a prescription, 5s that are exempt. And then they talk about all other drugs. And in Georgia, those drugs are thrown into the category of dangerous drugs. Different states call them different things. That's why NPJEs are hard. Some states, I think I mentioned this last week, actually call them C6s. How confusing would that be? Ours are not controlled substances, but they're dangerous drugs. Okay, same requirements. They have to be licensed as an APRN, but they also must have that nurse protocol. The nurse protocol is the counterpart that PAs have called the job description. Why they didn't call it a PA protocol and a nurse protocol, I don't know, but they had to make it more complicated. They did them at very different times. Nurse practitioners only have had prescriptive authority under prescriber for a relatively short number of years. I think it's still less than 10 here in Georgia. It's one of the last states in the country. she's never practiced in Georgia, but she doesn't like Georgia because they were so late allowing nurse practitioners to prescribe. Okay, so it must be in their nurse protocol. If they're going to prescribe controlled substances, they also have to have DEA registration. And we're going to loop back around and talk about what it takes to get a DEA registration and whether pharmacists have to get it or not. Most of the time not. And again, no code signature is required as long as all those other things are present. No refills on dangerous drugs over 12 months except for, and again, we always talk about the exceptions in law. Nurse practitioners, and most of them don't even know this, they have 24 months on oral contraceptives, hormone replacement therapy, and prenatal vitamins. Most of them don't know they have 12 months. And luckily that's the same, back to the previous slide, that's the same as physician assistants. Didn't always used to be that way. It's easier now. They've made them basically the same. PAs do not have that 24-month exception for those other drugs, assuming they may not be in as much that type of practice. It just never was done in that. The prescription requires everything that is required for a physician's prescription as far as what has to be on that when it's presented to the pharmacy. Again, plus the name, address, telephone number of the delegating physician, just like the PAs. If it's a controlled substance, it has to have the DEA. DEA numbers are usually pre-printed on there, so you kind of get to thinking, well, they're always supposed to be on there. Realize, as far as a law question, it only is required to be on there if it's a controlled substance. And I think this might be the first time we've talked about the NPI number, National Provider Identifier. All of you, and most of you I know work some in community pharmacy practice, know about NPI numbers because that's what we use to get paid by a third party. That's how they identify that prescriber. Of all the Sarah Jones, prescribers in the country, that NPI number is unique. It is also required on PA prescriptions. The main reason it's stated as being required on these prescriptions is because, again, these laws were written after the invention of the NPI number. It wasn't on the written prescription regulations for physicians, but it is on the electronic prescribing regulations. Okay? So basically, all prescriptions now should have the NPI number. Okay, we used to use, before the NPI number was around, we used the DEA number as the identifier, kind of assuming that all, at that time, physicians, dentists, podiatrists, veterinarians writing controlled substances had a DEA number, or writing any prescriptions had a DEA number so they could write controlled substances. Now there are more practitioners who may not have a DEA number for one reason or another. Either they don't need it or they can't get it. They might have had it and lost it. So the DEA number really should be used to designate or to verify that somebody has controlled substance prescribing privileges, not just as a way of submitting for a third-party payment. I've worked a little bit, and I know it's got to where you have to have both the DEA and the NPI in order to get paid on a lot of third parties. It used to be you had one or the other to go through it. Now it pretty much is going to require you to have that NPI. Okay? So it has become more common in practice, and it is the official way of identifying the prescriber. DEA number should just be used to verify that someone is allowed to prescribe controlled substances. Okay, here's the part that should make you feel a little bit better about what you have to do out there every day when you go to work this afternoon or whatever. And I put in here both the part about PAs and APRNs. Nothing in this rule above should be construed to create a presumption of liability, either civil or criminal, on the part of a pharmacist duly licensed who in good faith fills a prescription order presented by a patient which was issued by an APRN, and the one above it says issued by a physician's assistant. Again, you should be aware and know your prescribers, know your patients is the best way. But this doesn't mean you have to stop every time you get a PA prescription or a nurse practitioner prescription you haven't seen before and call them up and say, are you able to prescribe this class of drug? Or ask them what their job description titles them to do. Okay. That's the second kind of harder hit we've done on nurse practitioners and PAs. Anybody got any questions? Everybody pretty clear until we go on something else?
So you said that NPI is always needed, so so it's not just for nurse practitioners where the NPI has a prescription?
Yeah, the NPI number is the National Provider Identifier for all types of prescribers who are are authorized to be paid by third-party, basically government-funded insurance plans. So the NPI number it's not in the regs about written prescriptions, because that is so old, it predates the NPI number. Where you'll see it now, and this is where it gets confusing, you'll see it in the nurse practitioner and APRN, nurse practitioner and PA regs, and you will see it in the regulations for electronic prescribing. It'll say the electronic prescription should include that information. It is required that you have that in order to submit to a third-party plan. And again, that gets into third-party rules, but if you don't have it, it's going to come back and say that's not on file, or yours doesn't match, or something. It's going to try to give you a hard time submitting that chart. So it is required now for all electronic prescriptions, APRN, and PA prescriptions in Georgia. Okay. Oral prescriptions, refill authorization. This goes back to, what was that? Durham-Humphrey Amendment. This is for the Georgia-specific regulations that we're reading here, but again, this comes from the federal requirements in the Durham-Humphrey that allowed oral prescriptions to be taken by a pharmacy. It had to do with phones being completely available. You must include, as the person taking that, you need to include the name of the individual making the transmission, who you're talking to. Excuse me. Date, time, and location of origin. And that can be supplied, the location of origin can be the nurse's name at the doctor's office, or the person's name. Doesn't have to be a nurse. The person, the agent of the prescriber who's calling it in. It does require date and time. I have never heard of anybody getting into trouble with the Georgia Drugs and Narcotics agents for just putting a date down, but I've heard of many cases where a third party comes in doing an audit after the fact, say, aha, this calling prescription doesn't have a time on it. We're not going to pay for that. And we're going to take the money back that we paid your pharmacy for that. So it's law, but the third parties can use it to their advantage to decide they're not going to pay you for that. And in addition to date, put the time on there. A lot of pharmacies have started having a time stamp thing. They just run it through and it puts that on there. That's a good thing to do to make sure you have it on there every single time so you don't lose some of your reimbursement. No one other than the practitioner or an agent authorized by the practitioner shall transmit in any manner. Patients, people that used to work in an office, people acting like they work in the office, it is illegal. Not surprisingly for them to call this in. What does it take to be a practitioner's agent? Pretty much just the practitioner saying, call this into this pharmacy. Okay, so there's no requirement there. They don't have to be a medical professional, RN, MA, any of those designations. It can be the person answering the phone. But they are acting as the authorized agent of the practitioner in order to call that prescription in. Institutional setting, basically that's code for hospitals. You don't have to record that if you're getting a call in order to a hospital. This is the first time we've talked about this, but we'll see this all the way through, particularly the Georgia regs. Anytime a regulation comes through, or the Board of Pharmacy considers something that applies to community practice, they either think ahead of time, trying to give them credit for doing that, or the hospital member on the board, or some representatives from hospital pharmacy practice saying, wait a minute, that will kill us. We can't do that. We need to be exempted from that. And again, if it doesn't really apply, they usually do go ahead and exempt them from that. We'll see that many times over where things that are required for community practice are not required to be done in a hospital practice. Again, there's a lot of different regulations apply there, different kind of formularies. You'll talk about that a lot with Dr. May. So things are very different. Okay, this is one that gets people a little concerned. As far as who can prescribe controlled substances, it needs to be someone obviously licensed or otherwise authorized, and that, by doing that, they include a license as a physician, dentist, podiatrist, or veterinarian, or otherwise authorized in our state, APRN or PA, authorized through their nurse protocol or job description to prescribe controlled substances. It has to be in the usual course of their professional practice. Now, I realize dentists, for example, not trying to pick on dentists, but it's just easy to make an example of them. They're licensed to prescribe in Georgia, and they have DEA credentials, they can prescribe controlled substances. A lot of them do. You know, they inflict a lot of pain. So they prescribe controlled substances, but it needs to be in the course of preventing dental pain. It can't be because somebody, you know, has slipped and hurt their ankle. Oh, I can prescribe this hydrocodone, you know, no problem. That's not within their usual course of practice. This is where you, as a pharmacist, have to say, wait, that's not legit. Now, notice up here these little letters in the parentheses, medical practitioners. This is in the Medical Practice Act in Georgia, not in the Pharmacy Practice Act. But it is not allowed for a dentist, or say a podiatrist, or for sure a veterinarian, to prescribe outside of their practice area. Conversely, it's also not acceptable for a physician to prescribe for an animal. That happens sometimes. I have a very good friend who happens to be a physician in Athens. She's been around a long time, and she pretty much used to do whatever she wants to do. She had been on the medical board before. She came in a pharmacy, not one I was working in, but she wrote out a prescription for her dog and gave it to the pharmacist. Wouldn't you know it, the pharmacist she was giving that to as a spouse, a wife, who's a veterinarian. And so he said, you know you can't write this for your dog. She snatched it back from him, crossed it out, put her daughter's name on it, handed it back to him. So you know what was going on. But that's just that's a story that hopefully you won't ever forget, that veterinarians can't prescribe for humans. Humans should not prescribe for veterinarian use. And prescribing or ordering such substance must be for a legitimate medical purpose. Definitely not for continuing or helping out an addict who is supporting their habit. That requires special training and special credentialing in order to be able to do that. That's where it starts getting difficult and might make some people a little nervous because of the things you're thinking about in practice that you're in. I'm still in the Medical Act right now. And they refer to it as self-prescribing, but it also talks about controlled substances. They must be practicing in their usual course of practice. It should be for their own patient. And the treatment of a disease is being monitored by that physician that's writing the prescription. Not just a family member who needs something, you know, doesn't have time to go to the doctor. It's an ethical issue. It's not technically illegal. It's called an unprofessional practice. And because that bothers a lot of people, and maybe you've seen this done out in the real world, and you're just like, I don't think that was right, but I'm not sure why. Here it is. And this is in 360. Again, that's not the pharmacy reg, that's in the Medical Practice Act. Writing prescriptions for controlled substances, personal use, or except for documented emergencies for immediate family members is considered unprofessional conduct. And somebody's going to ask, well, is it illegal? And I'm going to say it says it's unprofessional conduct. It's against the board regulations, but it's not a law, it's a regulation. Most of the time, if somebody is abusing this privilege and gets caught doing that, they're going to invite them to come in and talk to the medical board. They're going to say, you know, go forth and sin no more. Don't do that. And could it put their medical license at risk? Possibly down the road, but hopefully it doesn't come to that. Right along with that, I put it in here because this is also frequently a concern. That second section there refers to consulting over electronic means. I get this call frequently. I had it just a few weeks ago from a friend of mine down in southeast Georgia. Is it legal for a physician to only see a patient via telemedicine and then he prescribe them controlled substance and send it to my store for me to fill? And I'm like, bottom line, no, don't get in that. Here's the reference on that. I said, here's the gold standard if you want to really figure it out. There's a lot of use of telemedicine, as they call it, in South Georgia because of the relative lack of professionals, medical professionals being accessible to people. So they do a lot of telemedicine, mostly to monitor patients, very legitimately. They modify their therapy for their blood pressure medicine or their diabetic medicine or things like that, but not for controlled substances. I said, if this person is using this prescriber who they can access electronically to write this controlled substance prescription, and they're right there in your community, because they can't get anybody in the community to write that prescription for them, don't even think about that. Do not get into that. So telemedicine is very legit. Using it as a way of getting around the usual, again, patient, prescriber, pharmacist triad relationship is not ethical and in most cases not legal. We'll talk about when you can do that, and particularly the use of it, and it is expanding. We've got more technology now. People can see somebody via telemedicine. They don't have to go into the physician's or prescriber's office. They don't have to be exposed to the flu, all those kind of things. There's a lot of good reasons to have telemedicine. It does expand practice, but not for the purpose of getting controlled substances when you can't get them through a more legitimate stream. Office use drugs. We've been talking here a little bit about compounding. Some of the things we talked about in the last few weeks. Office use has come up. We can provide, as a pharmacy, we are allowed to provide other pharmacies, and prescribers' offices with dangerous drugs. Everybody's clear on what that is. Through an invoice sale. It is not legal and it's not acceptable to have that prescriber walk into your pharmacy and say, I need some prednisone for office use. Let me write for a bottle of 520 milligram, and here's a prescription. What would it be? I'll pay you for it. That's not the legitimate way to do it. The legitimate way to do that, as a pharmacy selling to a prescriber's office, is through an invoice sale. It can look like a prescription, but it needs to be filed as an invoice where you file the drugs that you have coming in, the drugs that you might return, things like that. It needs to be filed in there as far as you providing it to the provider's office. It is not acceptable for you to do that with controlled substances. The prescriber there has to use a wholesale distributor or go to the manufacturer just like you would as a pharmacy. You don't want to get involved with supplying a prescriber's office with controlled substances. That is not allowed. DE permit issues, all that kind of stuff. As far as distributing controlled substances versus buying them from a wholesaler and dispensing them, that's all good. But as far as distributing them for use by another prescriber, can't do that. Okay, obligation to fill. This is one of those little bullet points in the book that it comes up, and there's only a few statements about it. This is a huge issue. You are not obligated in pharmacy practice, particularly in the state of Georgia, to fill any prescription that a patient brings in. You should be able to use your skills, your knowledge, your discretion, even as we will see in just a few minutes, your ethical and moral compass to determine whether you should fill this prescription or not. That is very powerful. Many states, it's called a conscience law. Georgia's is very short, but it's huge in implications. Many states have lost their conscience law because a pharmacist maybe acted a little too forcefully with someone, trying to impose their ethical or moral standards on a patient, and got into a confrontation, can get into the news media, things like this. Next thing you know, it goes all the way up through the boards of pharmacy, sometimes into the legislature, and there have been states that have removed the conscience law and actually require that the pharmacy fill it or make sure that the patient can get it filled. Not in Georgia. Technically, it's not a legal issue in Georgia, it's an ethical issue. There are guidelines by the American Pharmacy Association, which are very helpful, and I've got a link here, and that doesn't work here on this computer, we bring it up. But there are some guidelines there for you to use to evaluate that in your own mind as far as what you feel you can or cannot fill. I couldn't keep from putting your employer in there because realistically most of us in practicing pharmacy now are employees. And as much as when you see what's in the law, you'll say, that gives me the power. It does give you the power. As a pharmacist, it won't be held against you as far as your professional license goes. But if it goes against what your employer wants to have happen, believe me, they can make life miserable for you, or you may end up finding yourself looking for another job. So keep that in mind, and as you get closer to talking with people about future employment, permanent employment, things like this can come up. It can either be asked by your potential employer, what would you do in XYZ case? You might feel very strongly and feel like you want to have that conversation with your employer. Just be very careful with that because it does have huge implications. Oh no, okay, I got it. Sorry, I had that on the slide. There it is. This is back to the Georgia board regulations. to go back through this later when we're going through the Georgia board regs one by one. A code of professional conduct, just like we were talking about professional conduct under the medical board a few minutes ago. These are items that come up under the pharmacy board of professional conduct. And we're talking all the way through here about ethics, but self-referral, what is that? Error or uncertain prescriptions, what does all that mean? But right now, what we're talking about is way down here. And again, it's the letter N, and it's not even 2 full lines. Refusal to fill a prescription. It shall not be considered unprofessional conduct for any pharmacist to refuse to fill any prescription based on his or her professional judgment or ethical or moral beliefs. That gives you a lot of power, but also with a lot of power comes a lot of responsibility. You have to think about your patient. You have to think about the people you're working with. You have to think about the people that own the store. Just realize there's a lot of implications to this, and it has blown up on some people. It has had some issues here in Georgia. There was a store in North Georgia a few years ago, back when there was more controversy about the morning after pill, which has basically become OTC now, and it largely takes pharmacists out of the decision whether that should be provided or not. But in this particular case, the pharmacist felt very strongly against that. And if I remember all the details, it's been several years. I don't think the store even stocked the drug. Okay, that's one of the easiest ways. We don't have, go down the street. We don't stock it. Some states where this has been overturned actually require you to either stock these drugs or to have access to a place that does. So not in Georgia. But anyway, they not only told them they didn't have it, they also proceeded to, we'll use the term preach, their feelings to that person. Made them very uncomfortable. That was not looked at positively by the store. It made it to the local media. It was very uncomfortable for that pharmacist and the relationship of that pharmacist with their employer. So again, you have the power. This is the board saying they will not hold that as unprofessional behavior, but realize there are other people that might not feel that way. Okay? So make sure you stay on the right side of that issue. Kind of related to that is ownership of a prescription. This is very technical as far as both in federal and state law, but technically the patient, once that prescriber has given that prescription to that patient, electronic gets a little more difficult, but if they give that patient a prescription, that patient brings it to you and says, I'd like to have this prescription filled, and for whatever reason you decide not to fill it, if otherwise it's a legitimate prescription, you should return that prescription to the patient. The patient owns it. Okay? It becomes your possession, and you're required to keep it and file it if you fill it. The exception there, and that's what we spend a lot of time, as we know in law class, don't start grooming when I say except when. If you feel like it's an illegal prescription, and the pharmacist has some discretion there to decide whether they feel like this is a forgery, or somebody has changed the numbers on it, something like that, the pharmacist does not have to return it and can retain it, ideally to turn over to law enforcement to report the invalid prescription, forgery, or whatever. Now notice it says they can retain it, it doesn't say they have to retain it. And again, this is where you need to start thinking an ethical thing. It's not just you. And by golly, I'm a pharmacist, I am not going to let you get away with this. Realize when you're talking to somebody who maybe has an addiction and really needs that drug and happens to have a weapon on them, you can put yourself and your staff at risk. So I guarantee you law enforcement is going to tell you, don't you do that if you think you feel threatened. You go ahead and give it back to them and call us. Give us a tag number, that's great, or whatever. But it is not required that you stand up and be the barrier there. But if you feel comfortable, you say, I'm not going to be able to return this to you. Frequently people will say, we'll keep it, fill it for you, later in the day or tomorrow. You'll call law enforcement, they'll be there, the patient comes in, they approach them, that kind of thing. But again, you have to consider that situation on a case-by-case basis. But if you don't have a real strong feeling that it's an illegal prescription, you, for one reason or another, do not want to fill it, but you feel like the prescription is legal, you should return it to the patient. Okay, a couple of those ethical issues, hopefully you're thinking about those, and definitely if you have questions, we can talk about them, or you can shoot me an email if you have specifics, or, this happened one time and I really felt this way, and we'd be glad to talk to you about it. to the next topic, refills in general. We've talked about this as we've gone through each different type of prescription as defined. C2s, by definition, have no refill, except, not really refills, but we talked about those situations where you can partially fill it for a long-term care facility, hospice, or a critically ill patient. Other controlled substances, very specific. Those prescriptions expire 6 months after the date they're written, not the date they're first filled, or a maximum of 5 refills is specified. They don't specify 3 refills, obviously you don't fill it more than 3 times if it's still within 6 months. Dangerous drugs, once again, no specific limits. If there are to be refills, it should be specified on the prescription. And again, the continuity of that physician, patient, and since you have the prescription, pharmacy relationship, that triad has to be intact. Frequently the question comes up, if a practitioner dies in an area, particularly in one of these little South Georgia towns where there's only 1 or 2, and the other guy or girl can't take all these other patients, somebody's like, oh my gosh, you know, Doc Jones died, I need my blood pressure medicine, I need my diabetes meds. They have a period of time, up to 6 months, to find a new prescriber. If they're valid refills, you can continue filling that prescription. You can't continue filling it forever. And the GDNA will ask you, if they're looking specifically at, you know, prescriptive patterns of physicians in the area, you say, no, that person died, this person's looking for, you know, got an appointment, but it's going to be a few weeks. They do have to be pursuing another physician or prescriber, but they can have up to 6 months to change that over. The prescriptions don't expire immediately. PAs, nurse practitioners, we've already talked about, and just to be the way the law is, PA said not more than 12 months, APRN is not more than a year, except for those few cases where it's not more than 25 to 24 months. Same thing, 12 months a year. Okay, this is something I bet none of you have heard of. Yes, ma'am. Question?
So if a nurse practitioner writes for one of the things where they have the 2 years.
Oh, yeah. Go ahead. I know what you're going to ask me, and I should have said that.
How do we, why do they do it?
If it's a third party, they're going to say it expired because it's 12 months old, right?
Right.
Yeah, that's third party rule. C2s don't expire. Dangerous drugs don't expire. But when the person that's paying for them says that prescription is over 365 days old, they need to see the doctor. In all practical purposes, expires from the point, if that person says, I really need that drug, you're like, well, it'll be, you know, 95, 99. It's legal for you to bill it. They're not going to pay for it. They're going to say, yeah, go ahead and fax the doctor. I'll come back tomorrow. Or invariably, it's on Friday, and the physician's office is closed on Friday, and you got to give them some drugs to get them through till Monday. That leads up to the next thing. This is an area that I've never seen used in practice. It's been in the regs forever. It's something, unfortunately, one of those things you need to know for law class and MBJE. And, you know, file it away. It may come in useful. There has actually been a Georgia Board of Pharmacy rule on the books for many years called the Pharmacist's Ability to Refill, a 72-hour supply to cover that week. We do this all the time. We say, give me that bottle. And you write, you know, 9 on there, and give them 9 and say, and write a note so you can take that off when they get the refill. That's not legal. Okay? But we do it all the time. And the GDNA knows we do it. And again, you're doing it to support that patient's drug therapy, particularly if it's a drug they don't need to be off of. But here's the legal way to handle that. Again, never seen it in practice. The pharmacist can actually write a prescription, separate, non-refillable prescription, written by the pharmacist, who can't prescribe in Georgia, but documenting this is to continue therapy. And it will have a prescription number from which it was refilled to refer back to the prescription that they're doing it from, and they'll record on the patient's record. Basically, it goes in your computer. There's a new prescription that is not refillable, maximum 72-hour supply, but it's written, verified, validated by the pharmacist. Okay? Do it in every company. But that's been on the books for many years, and you need to at least know that mechanism is available to you. You should not employ this provision regularly for the same patient on the same medication. If the doctor didn't get back with you, you don't do that again for another 3 days, right? Even if you're just giving a few of their old bottle. Somewhere along the way, you got to have validation that that's still what they need to be on. And that the prescriber is still their prescriber, and all that's still legit. A lot of things that I know bother you today. But that's what we get into more as we get on into the practice-specific laws. Retention of prescription files, and this is always a source of debate. How long do I need to keep this record? Or how long do I need to keep this prescription? And it's all over the board as far as what different resources will tell you. Textbook, for those of you, and a few of you that were asking questions before the exam, told me you're using the text, kind of follow along and want to know where certain things were there, that's good. The text will say it's all over the board, 3 to 5 years. It's even more broad than that. In Georgia, state law, they specifically give you dates all the way through the law. Most of the time it's 2 years. 2 years for prescription, controlled substance purchases, your inventory records. 2 years after closing a pharmacy, those records have to be available if somebody needs to do it for see them for an investigation. One place where it's different, again, it gets into the newer regs for e-prescribing. A patient profile that receives e-prescribed prescriptions, you have to maintain it for 5 years after the last entry. Here's the overall bottom line answer. And again, I wish I had it right on here. We'll talk about this some more as we go through. CMS, we talked about CMS before, Center for Medicaid and Medicare Services. They're the ones that make all the rules for Medicare and Medicaid dispensing. They make all the rules for Part D. Anything that is paid for by government-funded, partially government-funded assistance, which is all Part D plans, you must maintain the records for 10 years. And right now, that's the longest one out there. So basically, safety valve is to make sure you keep everything for 10 years. Now that we have all this, everything's electronic, and we've got all these, multi-gigabyte, terabyte drives, you just keep it electronically forever, but you still need to keep that paper record for CMS for at least 10 years. Okay? So we will talk about specifics as we go through the regs. For Georgia, and again, I try not to get specific and play Georgia off against other places. Usually I'm going to lead you to a question that's going to say, it's going to include that 10-year CMS, and you're saying, that's the longest, that's what it's going to be. But specifically in Georgia law, a lot of things still say 2 years. I realize it's better to keep it longer than shorter. Along that line, even in hospital pharmacy rules, like I said, they exempt themselves from a lot of things to the board. They do require that a hospital pharmacy, the director of pharmacy, is kind of like a PIC in a hospital, has to be able to generate the medication profile of what medications were administered, delivered to a patient for 2 years. Again, since they're under CMS, they know they got to keep it for 10 years. Labeling of prescription drugs. This is something I think all of you know, but you see it and you don't even look at it so often. Just be able to recognize all these specific things that are required on a prescription bottle label on the package that's given to the patient. That last thing there, cautionary statements as required. That includes things like the auxiliary labels that are just good clinical practice as far as it'll just say as required for those in order for the patient to be compliant. Very specific for controlled drugs. That caution, federal law prohibits transfer without a prescription to an unauthorized patient. That's one it's very specific to controlled drugs. But because they want to make sure nobody forgets to do it, most of our prescription labels now have that pre-printed on there, right? Just realize it's not required unless it's a controlled substance. And it's a perfect example of what especially now that I have to wear these reading glasses all the time, just because we've got these laser printers that print really, really sharp, really, really small, doesn't mean we ought to use the smallest font that you might be able to read, because a patient sure can't read it. Not that any patient is worried about this federal caution, but again, it has to be on there. Must be on there. If you're in enough cutting labels or whatever to fit on there as a controlled substance, make sure you have that federal caution on the bottom package. Okay, we've talked about expiration dates a few times. We've talked about BUD, beyond use date. This is another time this comes up. Expiration date really most accurately refers to a manufacturer's container labeling, because they do the testing to verify that expiration date is at least a minimal time that that drug is still valid. And that means that it's at least 95%. That's on the next slide. It's got to be at least 95% potency. If it falls below that, it's expired. So they test it. They come up with a date. They put on the expiration date. And usually it's not anywhere near 95% potency. It's probably still 98% or 100% potency. But But they do testing, they verify, validate it, so that they can put that expiration date on there. When we put something on a bottle that we call an expiration date, we're mostly using guidelines. Technically, if you're using guidelines, it should be a beyond use date. And that's in transition now, kind of like the use of the NPI number. It will basically be the beyond use date of the bud instead of expiration date when it's something you're doing based on guidelines. For prescription vials, this is different than that repackaging stuff we talked about. It's different from med packs. For prescription vials, just the standard, putting a lisinopril in a prescription bottle, the expiration date or beyond use date should be the shorter of the original expiration date on the manufacturer's package or 1 year from dispensing. Totally different from repackaging. And repackaging was no more than 25% of remaining date for 6 months. This is for prescription vials. It should be no more than 1 year from dispensing or the original expiration date on the manufacturer's container, whichever is shorter. I had to throw this in here kind of as a joke. Homeopathic products are specifically exempt from the expiration date requirement. Kind of laugh about that because a lot of us in allopathic medicine kind of don't think homeopathic drugs are worth anything anyway, so why should they have an expiration date? They're not going to go bad, they don't work. I'm not as convinced of that as I used to be, and we can talk about that sometime if you'd like to. I've seen a lot of different things work over the years. We were talking about pain creams here before class. Just because we're taught or we learn that they're not effective, we need to make up your own mind on that. And believe me, you'll have patients that will be very convinced their homeopathy is working. At the end, this kind of circles back to the manufacturer expiration date. It is backed up by stability testing. By FDA regulation, it has to be at least 95% potent. Again, most of the time it's not anywhere near that. And drugs will last much longer than their expiration date on there, much longer in most cases than the expiration date you put on a prescription bottle. But it's out of your hands, and it's out of the manufacturer's hands as far as how it's stored. If it ends up in a back seat or a back window of a car in South Georgia in August, and it's 118 degrees in there, yeah, it's going to break down a lot quicker. So if it's stored in a controlled environment and kept in that prescription bottle, patients have to throw it away right away, not unless it's a drug that decays to something that's toxic. Tetracycline is the one that comes to mind, but there are a few others that you might know of that would be that. And technically, it's the last day of the month on the expiration date, but usually it just has month and year. Great test question. What day of the month, beginning of the month, end of the month, it's the end of the month. Cannot dispense at the expiration date. It's required that you move it from stock. If you keep it in your pharmacy, it has to be separated from your regular stock so that there's no way that somebody can come in on the next shift and by mistake send that out. The thing that always gets me about expiration dates, if you're ever working in a pharmacy, hopefully many of you have had the chance to be in a pharmacy when a GDNA agent comes to do an inspection. One of the things they always do is kind of look through the shelves. Invariably, they go to a particular drug, almost like they know it's there. They put their hand on it, pick up the bottle and say, this expired 3 months ago? They find something like that all the time. I know several of them pretty good, and I said, how in the world do y'all do that? I mean, we kind of try to keep track, and they're supposed to do this monthly, but we miss those. He said, because I've been to 6 pharmacies this month, and they all have the same wholesaler. All their drugs came in at the same time. They're all expired. So they're not as omniscient as you might think. They're like, yep, they found it over there, and I was checking yours, and sure enough, yours is expired too. Definitely cannot dispense it, should remove it from stock, either destroy it or return to manufacturer, or whoever you got it from. In those cases, a wholesaler. And we'll talk about that, and there's actually requirements by state law that your distributors, wholesalers, and manufacturers take those back from you. If they're unopened containers, and it's within a certain window of the expiration, they should issue you credit or replace it with a new drug. A lot of people feel like they just lose that. They do if they don't do anything about it. But if you go through the process, you should get your money back for that and get a replacement product. Very special procedures for destroying controlled substances. Depends on what environment you're in. We're going to cover that hot and heavy, but toward the end of the semester, so that it'll hopefully stick in your head. Different regs for community practice, different regs for hospital, different regs for long-term care facilities. So don't go destroying controlled substances without knowing what you're doing there, because you can get in trouble. And the GDNA will come in and say, your inventory says you should have this many of those drugs on hand. Where are they? all those expired, and we flush them down the toilet. That's not a good answer. Okay, last thing we'll cover today, finish up a little early, and get the road back down to the coast. The Poison Prevention Packaging Act. This is something to kind of lighten up at the end, because I know we talked about a lot of things that may be bothering you today, or things that you don't see in practice. It has to do with child-resistant packaging. Some more of the alphabet soup. CRP stands for child-resistant packaging. This is required for, we're talking mainly about prescription dispensing, but it's also a requirement in OTCs. We'll talk about that here with OTC marketed products. Especially if it's a product that's used for pain or arthritis or something like that, it is allowed the manufacturer make one package available without that safety closure, so that those poor folks with arthritis can open that bottle of Tylenol or ibuprofen when they need it. But it must be very clearly marked, not for households with small children, and you can kind of point that out to them, because again, these things can be very toxic, and there's a reason that they have these packaging protections. They're child-resistant packages. They're not child-proof packages. Sometimes I kind of, some will do it and say child-proof packaging. They're not child-proof. They're child-resistant. And this is administered by yet another federal agency. It's under the FDA. It's called the Consumer Product Safety Commission. And they're the ones that require all this child-resistant packaging that we use in pharmacy practice. All new and refill prescriptions must be in a CRP, unless. These are two different cases, one of which I think you probably hear of most frequently, but the prescriber can actually request it on a prescription. Say, please put in a non-child resistant package. But that's only good for that one prescription. Okay? A patient, however, if they are filling out their profile thing for you or signing your HIPAA release and ask about their preference, my theory on that is don't ask. Give them a child resistant package. And then if they have a problem with it, make them ask you, tell you, please don't give me any of those. If you ask them, if you put it on that paper, then every time they're going to check, don't get me child-resistant package, because it's going to be a problem for them. But when their grandchild comes in and takes that medication, they're going to be very, very sorry. But you're going to have the documentation, paperwork saying, look, they said don't put them on there. So anyway, my theory in ethical practice is don't even ask them. Give them a child-resistant package. Hopefully get one that's not that hard to use. Again, this is an exemption for hospital. If you're dispensing or the package is going to be used in a hospital where there are other people that are controlling the administration of the drugs, save their hands. They don't have to have a child-resistant package. One last thing that really will bother you in this Poison Prevention Packaging Act, it says a new body, the bottle, and the closure are required for every dispensing of a plastic container. How many people work in a pharmacy that throws out the old bottles every single time and puts in a new bottle? Few people do. Okay. That's good. They maybe just graduated from law. They know that they're supposed to do that. A lot of places don't realize that. As a pharmacist doing relief work in small pharmacies, I'm usually working with some techs, and I rely on those techs. And techs are repackaging stuff and putting it back in the bottles all the time. And they'll see me throw one away. They say, "Oh, don't do that, boss. Likes to save money. Use those again." Well, you have to balance that off between, these people are going to make or break your day. And that bottle's not really nasty. Yeah, I let it go through. But a lot of people don't realize it is actually in the Poison Prevention Packaging Act, not a Georgia law, but federal regulation, that a plastic container, which essentially all of them are now, has to be replaced each time. If it's a glass container, I actually worked in one pharmacy years ago that had glass bottles for their pills. They had plastic tops. Glass can be reused because it technically doesn't wear out, but you should replace the plastic closure. We have to go practical now, but it's still in the law. You may use reversible closures, and a lot of us do that, and it makes it easy, especially those you can just pop the sides up, and the patient can go merrily along their way without the child-resistant packaging. That is allowed, but it's not recommended. Again, CPSC, Consumer Product Safety Commission, they're doing this to prevent poisons. So they frown on that. There's some exempt products. Again, must use them all the time except in these cases. Most of the time these make sense. Inhalation therapy, you've got to be able to access that and put it in the nebulizer, things like that. Cholestyramine powder. Erythromycin packages, I have not been able to figure that out. The only thing people can tell me on that is that it is so non-toxic that you just don't need to have it. But somewhere along the way, somebody lobbied to get erythromycin exempt from child-resistant nitroglycerin tablets, other nitrates for obvious reasons. You want to make it as easy as possible for someone in distress to be able to get into those. Oral contraceptives, you know, those kind of those annoying little blister packs. They don't have to be otherwise child resistant. Those are relatively child resistant anyway, just like the prednisone and Medrol, those packs. But it's not required that they be in child resistant packaging. Okay, this is the final part, and I just love this, because you always suspect this, but you don't know until you finally see it now it's actually law. When the Consumer Product Safety Commission tests containers, there's actually two test groups of people. There's the children they're trying to protect, under 5 years old, and there's a group of adults that are 50 to 70 years old. And I can fit into that group somewhere in the middle. So they do test it. And you can tell when you have these patients that come in and say, oh, please don't put it in those things. It is a little, you know, icebreaker with them. Say, you know, it's actually been tested on people 50 to 70 years old to make sure they can get into these things. The rule, in order to pass for those 5-year-old and less children, the package fails if more than 20%, more than 2 out of 10 can open it in 10 minutes. Most of those guys are pretty savvy, and I think a lot of them can still do it. The rule is they can't, 20% of them, no more than 20% of them should be able to open it in 10 minutes or else it fails. They got to go back and make it a little harder. But here's the best part, the adults. 90% of adults 50 to 70 years must be able to open it within 5 minutes the first time, but the second time, the subsequent times, they should be able to open it in a minute once they get it figured out. Of course, you know, if you go to different pharmacies or you use different bottles, they have to figure out every different one. Like I say, we'll stop there, but I will tell you one of my best experiences with a problem with somebody opening their child-resistant container was somebody, and you know how this happens, they give you a paper bag of all their prescriptions, and you're like, oh, you don't even want to look in there and see what all's in there. This one was heavy. I opened it up, I looked in it, and I pulled out, and there was actually a bottle with a pair of vice grips on the packaging thing where they had used that to open the bottle, and they had just left them clipped on there. So we asked him, I said, you want this vice grip back? And he said, yeah, you know, put it back in there. We'll get it open one time. The other thing, and I know this happens a lot, I see it quite often, people will mark the top of their bottles as far as their AM meds or their PM meds or things like that. So you know it's a system they have. And again, letter of the law, new package and closure every time. Have I at least thrown those in the bag, or have I put those on the new bottle and given them back to them? Yeah. I do that. But again, just know it's one of those things like I used to say, you know you're going to break some laws in practicing pharmacy the way you should. Good ethical pharmacy practice. Just know which law you're breaking and know why you're doing it, and you're doing it in the interest of patient safety and patient compliance. They're going to back you up. Okay, we'll stop with the Tylenol scare, and we'll start back on that. Next week, y'all have a great Valentine's Day, and who knows where I'll be next week. I'm glad to be here in Augusta with y'all today, and glad to see everybody still in place over there in Savannah. They know it's going to be gone, but they still showed up. I appreciate that. And we will see you all soon.